Good afternoon, and welcome back to the Symposium. At this time, it is my honor to welcome our keynote speaker, Dr. Robert Pearl. Dr. Pearl is the former CEO of the Permanente Medical Group, the nation's largest medical group, and former president of the Mid-Atlantic Permanente Medical Group. In these roles, he led over 10,000 physicians, 38,000 staff, and was responsible for the nationally recognized medical care of 5 million Kaiser Permanente members on the West and East Coasts. Named one of modern healthcare's 50 most influential physician leaders, Dr. Pearl is an advocate for the power of integrated, prepaid, technologically advanced, and physician-led healthcare delivery. He serves as a clinical professor of plastic surgery at Stanford University School of Medicine and is on the faculty of the Stanford Graduate School of Business, where he teaches courses on strategy and leadership and lectures on information technology and healthcare policy. He is the author of Mistreated, Why We Think We're Getting Good Healthcare and Why We're Usually Wrong, a Washington Post bestseller that offers a roadmap for transforming American healthcare. All proceeds from the book go to Doctors Without Borders. His most recent book, Uncaring, How the Culture of Medicine Kills Doctors and Patients, was published in May 2021. Dr. Pearl hosts the popular podcast, Fixing Healthcare, and Coronavirus, The Truth. He publishes a newsletter with over 12,000 subscribers called Monthly Musings on American Healthcare and is a regular contributor to Forbes. He has been featured on CBS This Morning, CNBC, NPR, and in Time, USA Today, and Bloomberg News. He has published more than 100 articles in medical journals and contributed to numerous books. A frequent keynote speaker at healthcare and medical technology conferences, Dr. Pearl has addressed the Commonwealth Club, the World Healthcare Congress, the Institute for Healthcare Improvement's National Quality Forum, and the National Committee for Quality Improvement, or NCQA. Board certified in plastic and reconstructive surgery, Pearl received his medical degree from the Yale University School of Medicine, followed by a residency in plastic and reconstructive surgery at Stanford University. From 2012 through 2017, he served as chairman of the Council of Accountable Physician Practices, which includes the nation's largest and best multi-specialty medical groups, and participated in the bipartisan Congressional Task Force on Delivery System Reform and Health IT in Washington, D.C. Please join me in welcoming Dr. Robert Pearl to our symposium. Dr. Pearl?
Well, good afternoon, and Provost Utah, thank you so much for that kind and overly generous introduction. I want to congratulate you and congratulate all of your staff and faculty on this incredible day, the dedication of this library and the remarkable work that Howard University has done across time now into the future at both promoting medical care and diminishing disparities. And I'll be speaking about that this morning and then looking forward to people's questions. So let me begin with the observation that there is no longer any doubt about the size and the significance of healthcare disparities. We know that Black patients don't get the preventive services that they deserve, the same services that white patients receive. We know that they experience far more complications from chronic disease than white patients. And in every measure of clinical outcome, the care provided is not equivalent, not equal, not as good. The question is, why? COVID-19, the current pandemic, has given us insights into this problem of healthcare disparities. What we have seen is that Black individuals have a 2 to 3 times higher mortality rate than white patients. I asked physicians when the data became available. Why do you think this is? And they had a lot of explanations, all of them about the broken system of American healthcare and the problems in American society. They pointed out that African Americans often work in jobs that require that they be there in person rather than being able to quarantine at home and connect on Zoom. They talked about the buses and the subways that these individuals often had to use to get to work, in closed containers packed with people that were opportunities for the virus to easily spread. And they spoke about the multi-generation households that often they lived in, with children bringing home the virus and parents and grandparents often coming down and succumbing from the disease. But what they didn't talk about was that early in the pandemic, when there were not enough testing kits and 2 patients came to the ED with exactly the same symptoms, one a white patient and one a black patient, the doctors in the ED, most of whom were white, tested the white patient twice as often as the black patient. And that made no sense. Why would you test the patients whose chance of dying are so much less? Why wouldn't you preferentially test those individuals at the greatest risk? And what I discovered, what I wrote about in the book Uncaring that the provost spoke about, and anyone who wants more information can find it on my website, robertpearlmd.com, that standing in the way was not just these systemic elements, it was also cultural. And like the 2 snakes that are entwined around the staff in the caduceus, that symbol that doctors wear on the white coats and that are adorned on the cover of many of the books in the library, at the system of medicine and the culture of medicine are intertwined and impossible to separate one from the other. Let me give you another example. We know that Black individuals have a lower vaccination rate than white individuals. And when I ask physicians why this should be, again, they have a long list of systemic reasons. First, they point to problems at work getting away and issues around transportation. Then they talk about concerns about the healthcare system mistrust, dating all the way back to the Tuskegee syphilis experiment on humans. But what they don't speak about is how the medical profession chose to release the vaccine. Started by giving it to healthcare professionals and people in nursing homes. Made total sense. Healthcare professionals are the ones most exposed, and those in the nursing homes had the highest mortality rate. Next, we gave it to the elderly and to individuals with multiple chronic diseases. Again, completely logical. These were the people most likely to get hospitalized and die. But why wasn't the third group Black Americans? If there's a 2 to 3 times higher rate of death in that population, we should have singled it out, but we didn't. For the culture of medicine, healthcare disparities are not seen as very significant. So what is medical culture? Medical culture, it's the values, the beliefs, the norms that doctors learn in medical school and in residency, and that they carry with them their entire career. They don't learn it in classrooms, in lecture halls. Can't find it in any textbooks. No, they learn it by observing those who are senior to them, emulating their behavior, embracing their values and beliefs, even when they are not what is best at the current time. To better understand this culture, let's go back to Vienna, Austria in 1850. Ignaz Semmelweis is appointed the head of the maternity service at the leading hospital in Europe. And he is appalled. The mortality rate in women delivering 18%. And he's embarrassed because the facility next door, one run by nurse midwives, not by the leading academic physicians of Europe, has the mortality 2/3 lower. At the time, the leading cause of death was an infection called puerperal fever, an infection that began in the uterus postpartum, spread to the body, crossed throughout the body, killing the woman. And the cause was said to be miasmas, smelly particles drifting up from the streets below. But Semmelweis says, why should our patients, our women in labor, who breathe the same air as the women in the facility next door, why should they die so much more frequently? And often in medicine, discoveries are made through serendipity. And a colleague of his, while performing an autopsy on a woman who dies from puerperal fever, nicks his finger. And he develops a local infection that spreads through his body and kills him with exactly the same clinical course as the women who die following childbirth. Semmelweis says, maybe what's happening is these doctors are carrying something from the autopsy area to the delivery area. Or maybe it's something on the leather aprons that they wore at the time to cover their well-pressed three-piece suits. And he said that every doctor, before they enter the maternity area, would change that leather apron, dip his hands, they were all men at the time, dip his hands into chlorinated water. Lo and behold, mortality drops from 18% to under 2%, a 90% reduction. He writes it up in the leading journals. He sends letters to the directors of the services in other hospitals across Europe. And guess what happens? Nothing. Nothing changes. It's going to be decades before Pasteur comes along. And in the interim, tens of thousands of women are going to die. Now, I want you to think about, why should this be? You know, we often say there's not enough time or not enough money. It didn't take any time or money to change that apron or dip your hands in chlorinated water. It's that culture. It's that culture. It elevated doctors that said they're healers. They couldn't possibly be the source of infection. And those leather aprons, they're symbols, and in culture, symbols are big. They're symbols of experience. And the idea that they could be causing infection didn't seem possible. Now, fast forward 150 years to today. The leading cause of death in hospitals in the United States is hospital-acquired infection. The most common bacterium, Clostridium difficile. Doctors know, every doctor knows it doesn't travel through the air like the coronavirus. It's carried in people's hands. And yet multiple studies from across the United States have shown that 1 in 3 times when doctors go from one room to the next, they fail to wash their hands. It's not time, it's not money. Alcohol-based disinfectants are at every door. It takes seconds. It's the same culture. It's the same culture that is killing people today as it did in the past. And embedded in that culture are the disparities in healthcare that exist based upon race. Intrinsic in the culture of medicine are two defense mechanisms: denial and repression. They're both very important historically. Doctors until the middle of the 20th century had very little to offer to patients outside of a very few operative procedures. They had to deny the minimal impact they had in order to keep their status elevated. And they had to repress the emotions, losing patients, being helpless in the face of death to keep doing their work. But this culture is not solely bad. Think about in the early phases of COVID-19. Doctors would go to the hospital 12 and 24 hours a day to take care of patients. The doctors didn't have the protection they needed and deserved. They often would have to wear garbage bags when there were no gowns, salad lids when there were no masks. They knew that every time they passed the tube through the patient's mouth into the patient's lung in order to save their life, as that tube went through the vocal cords, the patient would cough, spewing virus in their face, and they did it anyway, being able to deny the risk, repress the fear. But it's those same defense mechanisms that blind physicians to their role in healthcare disparities. Ask doctors, and they'll tell you, we treat every patient the same. Look at the data. It's not true. Black patients receive 40% less pain medication after the same procedures as white patients. They're offered breast reconstruction after mastectomy far less often. And in an amazing research study, researchers took scenarios about patients with chest pain coming to the ED, and all they changed between them was the race of the patient. And they gave it to individuals, to physicians to evaluate, and consistently, doctors would intervene earlier, would have a higher concern about the possibility of a heart attack, would offer treatment earlier and more aggressively to the white patients and the Black patients, even though the information was identical. This is embedded in the culture of medicine. But I don't think, although there may be exceptions, that it truly is racist physicians or individuals intentionally discriminating. No, I don't think so. I think most people are not aware of what's going on. And we can understand it from research coming out of Harvard about implicit bias. Their researchers did an experiment. They took two sets of words. One said positive, one said negative. Positive words were like smart and caring. Negative words were uneducated and aggressive or violent. And then they took these words and they showed it to subjects and they asked them whether the word was a positive word or a negative word. They had to click either a positive or negative. And the amount of time that it took them to recognize smart on a Black face as opposed to a white face was far longer. And the amount of time that it took to recognize violent as opposed to caring was much shorter. The implicit bias sits inside physicians, as it sits inside all of us. And I think that it derives from 20,000 years ago. If you think about it, our ancestors were in caves. A figure would show up at the door and we had a nanosecond to figure out, was this someone from our group? So we'd welcome them in, or was this someone from another group coming to harm us and we'd have to throw the spear at them? Implicit bias, I believe, is part of the human condition. But what's not is the failure to recognize that it exists and the failure to see the consequences it has. And that, to me, is racism at work. And American medicine has failed to appropriately recognize the healthcare disparities and the consequences that are there. The truth is that we don't feel the pain of people that we don't see as being like us. And I believe that Black patients have suffered as a consequence and continue to do so today. You know, it's interesting, about 2 years ago, there was information coming out from United Healthcare. And United Healthcare decided that what it wanted to do was identify patients who are most likely to become very sick and invest resources in maximizing their health to try to prevent it. A very laudable goal. But they couldn't quite figure out, you know, which is worse, a heart problem or a diabetes problem, a neurologic problem, a psychological problem. So they used an artificial intelligence application to select the people who would benefit the most from the added resources. And then when researchers went in and looked, they noted the fact that there should have been about 47% of the individuals selected to have been Black patients. But instead, there was only 18%. As media, social media, print media got all over this, headlines read, AI racist. That's not what happened at all. You see, the problem was that the AI application assumed that if you had more things done, if you were tested more aggressively and earlier, if you were given more effective medications, that would mean that you were sicker. But in practice, what happened is that doctors gave Black patients $1,800 less care per year. So when AI looked at the data, it looked as though they were not nearly as sick as their white counterparts. It wasn't the AI that was biased and discriminatory. It was the physicians providing that care. So what can we do about it? What should we do about it? How do we address these aspects that are intrinsic in the physician culture? We have to address the systemic issues. Make no doubt about it. We need to expand coverage to all Americans. We need to be able to address social determinants. We need to find ways to make it easier for people to get vaccinated and get information. There's a lot of things that we have to do around the systems. But I think we also have to address the culture now that we know that is there. One thing I believe we should do is talk about implicit bias in medical school and residency. For if you don't recognize the fact that your actions are likely to be inappropriate, that you're likely to treat some people not as well as others, you're likely to continue to do so. But I'm hopeful that as people learn about it, they'll second guess themselves. And when confronting a problem, particularly for a patient they are likely to diminish the care they provide, they'll look twice and think twice and start to close that gap. The second thing is I think that artificial intelligence can help them. It can help them because they can look at the differences in practice based upon race. And when a physician orders insufficient pain medication, or fails to recommend breast reconstruction, or fails to order the appropriate heart test quickly enough, the AI application can at least raise the question, are you sure you're treating this patient as well as you're treating your other patients? But finally, and I think maybe the best solution comes out of another set of data, or two sets of data, actually. We know that Black women have 3 times the death rate during child delivery as white women. Ask doctors about why this is, and they'll tell you a variety of reasons for insufficient prenatal care to challenges once the women get home. We also know that Black patients don't get the preventive services they require. And again, ask people why that is. They'll have a litany of reasons about challenges around transportation and issues around nutrition. And again, all of these things are right. But we also know that when the obstetrician is a Black physician, when the primary care doctor is a Black physician, the discrepancies disappear. And so I think one of the most important things we can do is to train far more Black physicians than we do today. I think they will be the ones to notice when the care that is being given is not the same, when the healthcare disparities are likely to result. They're the ones who are likely to speak out and to transform not just the system of medicine, but also the culture of medicine. And I'd be remiss not to commend Howard University for the large number of Black physicians that it has trained, many of whom have been my colleagues, my most respected colleagues. I think you've made a tremendous contribution in the past, and I look forward to the contributions of the future. I welcome your questions, and I thank you.
Thank you so much, Dr. Pearl, for all of those insights that you have shared with us today. I'm checking with the chat to see if there are any questions. And if there are, I'm seeing if there are now. If there are none, it looks like we have none. We are going on to the next session. So I want to thank you very much again for joining us for this important session today, Dr. Pearl.
It's been my pleasure. Congratulations to all, and thanks the attendees for coming and for being as concerned about the disparities exist that us and myself and the other leaders and organizers of today's event are. Thank you so much.
Thank you again. Good afternoon again. There is a question. Hold on, Dr.
Okay.
Pearl. It looks like we do have a question. Yes, sir. It says that I think training more Black physicians is great, but what will be done or what can be done for those with implicit biases, sir?
Well, that's why I was saying, I think the first thing is to make them aware of it. And it's not those with it, it's everyone. And I think particularly because right now medicine is a white physician dominated world, that's the reality. And I always believe in facing the truth. We know that Black patients are not going to get the same care. That just because of this 20,000-year-old problem, the physician is not going to feel this pain as much. And if that's the reality, what I believe we need to do is to talk about it, to acknowledge it, and to recognize that we have to do something about it. And I think what we can do, as I said, besides educating people, is to look at a continual basis about what the difference is. Why do Black women have 3 times the mortality? We should be able to figure that out, particularly with artificial intelligence, being able to look at the management. We should look at opportunities. What would happen if more of the nurses were Black nurses? Or if more of the dietitians, respiratory therapists, doctors, it doesn't matter. We should be able to look for solutions. And again, I would say that if the tables were turned, we would definitely be doing it. And the fact that we're not is a reflection to me of the racism that exists in medicine and society. And I think the time has come to address it. If we're going to improve the health of all Americans, we have to improve the health of everyone. And when you have this level of discrepancy between what should be and what is, to me, it's an obligation to move forward. which is the focus of this two-day conference.
Thank you so much, Dr. Pearl. We do have one final question. What are some steps being taken currently, sir, to address health disparities in general?
Well, I think in terms of healthcare disparities, there's a lot of conversation happening around it. People are identifying some of the difficulties, and we have to acknowledge the systemic ones. I mean, there are socioeconomic issues. If you can't earn a living that's capable of allowing you to have good nutrition, you're going to not only for yourself, but for your kids, provide food that is going to lead to a higher rate of diabetes and heart disease and all the problems that go along with that, because you have no choice. And if you have issues with transportation because of where the roads are created and where the access is going to be, it's going to be harder to get the preventive services. And if you have a job that doesn't provide the leave to go get your mammogram or your colonoscopy without fear of losing income or fear of losing your job, you can't get these things. And so we have to recognize the socioeconomics, the social overall, and I don't want to minimize that at all. But we also have to look at these other pieces. And I think that that's where the training has to come from. What medical schools and residencies have tried to do is to offer lectures, to bring in guests like yourself or the provost from leading communication and academic institutions to be able to be speakers on this issue. But there's a gap, there's an emotional gap between your brain and your heart. And we have to understand that. You can recognize that just like the people in Semmelweis's time did. And yet you cannot take the actions that are necessary. And that's, as I say, why I believe it's so important. We're never going to have enough Black physicians to take care of all the Black patients because the match isn't going to be exactly right. Who's on call tonight? Maybe someone different than the race of the individual who is there. But we can have every physician be aware of it. And I believe that if we had more Black physicians who would be there to speak up, to notice what's going on, that we could move this culture and close that gap going forward. It's something I've worked hard from when I was the CEO in Kaiser Permanente. And I have, again, quite a bit of information for any of the viewers and listeners who want more on the website, robertpearlmd.com. I think that together we can make American medicine the best in the world once again, which it's not today. And a major part of that will be eliminating the disparities based upon race and based upon other categories as well. But that's the focus of today's two-day program. So thank you so much for having me.
Thank you so much, Dr. Pearl. I want to make a couple of comments from a communication standpoint. What we do know as communicators is that in order to inform the public and make them aware about all of what's going on with health disparities or whatever those issues are, many times you have to go out into their communities. You have to meet them where they are. It's not just about holding the symposiums. These are excellent starts, but you have to get out there so you can be next to them in their communities, in their churches, in their homes, or whatever those activities that they are having in those communities. And secondly, I wanted to mention, you made a very good point about Black physicians being able to share that kind of information with others. One of the things that we should hold our own news stations responsible for is to make sure that you are bringing on experts who are Black physicians when you need to talk about some of these issues, and not just other people of the majority, but people who look like me, people who look like many of the other Black physicians or ethnic physicians. I think those are important points that I wanted to make from a communication standpoint. And finally, there was one other participant who wanted to mention that there's a book, Biased, by Jennifer Eberhardt. It's an excellent, helpful book in understanding implicit bias. So I just wanted to share all of that with the audience and with you, and to thank you so very much, sir, for your major contributions to this symposium today.
Thank you again, and congratulations on the new library.
Thank you, sir. I will want to go again and just say good afternoon to all of the participants that are here. If you're joining us now or have been with us, welcome again to the 20th anniversary of the Lewis Stokes Health Sciences Library and Vernon E. Jordan Law Library at Howard University. We're conducting these two half-day symposiums focusing on the challenges and legal implications of misinformation in health disparities and health policies that affect minority groups in the United States. I'm Sheila Brooks. I'm CEO of Washington, D.C. marketing agency SRB Communications. I'm delighted to serve as your moderator today. But most importantly, I'm a proud Howard University alum. Let me share a few other housekeeping matters with you before we go on to our next session in a few minutes. We'll be taking about a 5 to 7 minute break before we move to the next session. Please take the time to network in the chat box if you haven't. You will be introduced later when we start again to all of our panelists, immediately followed by each of them sharing their research and presentations. You should place your questions in the chat throughout the sessions, and then we'll take questions after each panelist has presented all of their work. We're keeping today's event on time, so please join us again on time according to your schedule, promptly at 2:30. It is now 2:24, and we will begin shortly. Please stand by.